Our next speaker is Dr. Melissa Hayden. She is Senior Vice President at the Home of the Innocents, and she oversees behavioral health services and residential treatment and emergency shelter program there. She previously served as the director of the Jefferson County Internship Consortium at 7 County Services. She received her master's degree from University of Tennessee and her doctorate in psychology from Spalding University. She serves as co-team leader with the Kentucky Judicial Commission on Mental Health, the section on dependency, neglect, and abuse. And she also graduated from the Leadership Louisville class of 2023. She will speak to us today on mental health challenges of displaced youth. And it looks like you've got somebody else to introduce to us, Melissa. So we are happy to let you take it away.
Sure. Good morning, everyone. Thank you for joining us on a Friday morning. Thank you for that introduction. Like she said, my name is Melissa Hayden. I'm the Senior VP here at Home of the Innocents. And I brought with me today a Vice President of mine who is well known around the state for his expertise on homelessness, especially youth experiencing homelessness. And I'll let him introduce herself.
Thanks, Melissa. I'm Joe Hamilton. So I've been working with the homeless for about 19 years in Louisville, and previously was in leadership positions at Louisville Metro and at the cabinet in Frankfurt. And I've been with Melissa the last 5 years here in nonprofit land. So. And
I'm going to give a shout out. You won't see her because she won't come on the camera, but Carrie Hardaway is running all of our tech, our polls that will launch, and has been instrumental in helping us get this up and running. She's much more tech savvy than we are, so we appreciate her. So we're going to start today. There will be several points today. We'll do a brief poll or chat questions. We'd love to invite you to participate in discussion and engage with the topic. So we will try to be as hands-on as possible, even though we're in this virtual environment. You'll see the agenda and the different topics that we are going to cover. So we're going to quickly launch a poll just to get everybody ready for this with a basic question. You'll see the green arrow up top that shows you how to answer. But if you'll go ahead and submit your answers of how do you define homelessness? How are we doing, Carrie? We're still waiting.
Still waiting on some people. So someone said complicated.
All right, so we don't want to hold everybody up.
Without stable shelter, unhoused, unsafe environment, nothing consistent, not having housing stability, traumatic, being without secure, stable housing of your own, without consistent shelter.
So very much so. And Joe, if I'm gonna let you take it from here on what are the technical definitions that we find.
Yeah, whoever said complicated, I think that might take the award. So there are several federal definitions of homeless. The most common that we use here at the home is the Department of HUD, the Housing and Urban Development definition. And it really is the most strict of the federal definitions. And it's Department of Education and the Runaway and Homeless Youth Act definitions are a little bit less strict in that they allow for couch surfing and being doubled up, where you're staying with family and friends. States don't really do a great job of separate definitions. A lot of them, it rolls up to the federal definition, but there are several states that do define homeless youth. There's about 12 states that do that. Kentucky is not one of those states. We are one of the states that define runaway youth. There's 8 other states besides Kentucky that also define runaway youth. And there's 12 states that define both homeless youth and runaway youth. And then there's 18 states that don't define either. So it just rolls up to the federal definition. So the takeaway is it's very complicated. There's several different definitions, which adds to some of the definition issues, struggles.
Well, and I will tell you one of the reasons that we rely on the HUD definition, and most other places around the country do, is because this is the only definition that offers direct housing. So your other definitions don't even offer the housing. So most people opt into the HUD because you have that housing resource available.
Exactly.
So this is just a map of the words definitions combined. Words that stand out to you, and we may go through that, but you know, one of the things that I keep going back to that I like it is complicated, and we'll hear that throughout this presentation. So we're going to ask you this time to get ready to guess a statistic. So you'll see there's a polling button at the top. It looks like a little graph chart. But what percentage of youth do you think experience homelessness each year? And youth is vaguely defined as 12 to 24. Right.
So the results were everyone 47% guessed 10% and 41% guessed 30%.
You 10%ers are right. So there's about 10% of all youth experience homelessness each year. This graph will show you the details, but what we definitely know is that race and sexual orientation double the likelihood of a youth facing homelessness in a given year. 1/3 of Kentucky's youth who age out of foster care will become homeless before the age of 21.
Yeah, so this is an interesting slide. Obviously, homelessness has increased throughout the country the last 5 years. Louisville is no exception, especially when you look at the youth numbers. And one of the interesting things is that Louisville was one of 12 communities that qualified as a youth homelessness demonstration program community. And so we got $3.6 million back in 2019 to specifically address youth and young adult homelessness. And you can see here that our numbers have increased by 71% during those 5 years. So despite that injection of resources, it's nowhere near the need to solve the issue.
It's a sobering stat, 71% in 5 years. When we pulled this together, it's one of the ones that really stood out to me. So you're probably gonna hear us a lot. I know Dr. Ross referenced it earlier, but going back to the ACEs study. So this is a study that was conducted with 119 youth in Kentuckiana. That's defined as Louisville, Jefferson County area, as well as Southern Indiana. And they examined the ACEs and sex trafficking and youth experiencing homelessness. Not surprisingly, they found that youth experiencing homelessness had significantly higher ACE scores than the general population, and that youth who were experiencing homelessness and had been sex trafficked, which we know goes up in the youth with homelessness population, had even higher ACE scores. If you'll note this morning, Dr. Ross mentioned that each additional ACE score increases suicidality by 60%. So if you overlay her statistic here with the data that we're showing you, you'll see why mental health, suicidality, and some other diagnoses really stand out. That's overwhelmingly high in this population. Also, 4+ ACEs, as Dr. Ross mentioned this earlier, have disproportionate share of every health and social economic impact that we study. So in this study, what they noted is those that are serving youth that are experiencing homelessness should require additional training and resources on sex trafficking and human trafficking. It's a really high statistic and correlation within the population. So identification, screening, and assessment of youth who are experiencing homelessness, overlay with a sex trafficking tool to assess for that as well. And that helps us connect them with more appropriate resources. Launch another quick chat. Again, we're trying to keep you engaged on your toes this Friday morning. So how does your role assist in trauma-informed care for the youth of Kentuckiana? And we have a lot of different professions represented. So I would expect to see a variety of answers as how your role is impacted in the trauma-informed care we provide. We're going to look to Carrie for that one.
Waiting on some comments. Education to staff, advocacy and education. We provide trauma-informed training providers in our system, therapists, direct trauma services for youth, providing trauma therapy, assisting, connecting to resources, being aware that we're able to provide support. Our health department provides TOP club sessions in our schools, trauma-informed care for my therapy clients, educating volunteers, school-based therapists, understanding of use, trauma-informed care staff, direct service to clients, training staff and coworkers on trauma-informed care. Lots of great response.
And what I love is what we are hopeful to do as we created this and looked at the audience here, is we knew there was a plethora of different professions. So we prepared our presentation to make sure that we are hitting the different professions that are represented in this audience today. You were all spot on. Lots of things that we're all doing, very different things, but also some commonality amongst those. So kind of blowing away with some sober statistics. This one is a hard one to see, but after reaching the age of 18, 20% of children who were in foster care will instantly become homeless. So how does this all intersect? What is youth homelessness and mental health? What are the intersectionality between those? All this data right here is from a sample of youth who were currently or had experienced homelessness. And what they said is family conflict or disagreement is the top reason youth gave for the reason they were homeless. And the top risk factors for family conflict were the youth's sexual orientation, school problems, pregnancy, and substance abuse. Within youth experiencing homelessness, there were disproportionately higher rates of untreated mental health problems. The youth were particularly vulnerable to the effects of homelessness. They were at higher risk for experiencing trauma, victimization, including sex trafficking and human trafficking. Depression, anger, and adjustment were the most common presenting mental health concerns. And one of the things that stuck out to us as we talk about trauma-informed care, trauma was not identified as a primary concern for any of these youth. We recognize it as providers, and what the youth has told us is you all push that on us, and they don't want to hear it. If we looked at where they're currently functioning and what's important to them at the moment, their trauma is not. It's about some other priorities that we'll talk about in just a minute. So, poll question: what percentage of youth experiencing homelessness met criteria for one or more mental behavioral health disorders? You have your options down there at the bottom. We did try to narrow it down for you a little bit. These awkward pauses while we wait.
No, we need Jeopardy.
We should get Jeopardy music.
So 57% guessed 71% and 25% guessed 89%.
So we definitely know they are high. 89%. This slide informs us that the mental behavioral health needs within this population are extremely high. So for 16 to 19-year-olds, 89% had one or more. If you compare that to the national populations in the same age group, the national population is only at 30%. So we're talking about 60% difference with youth experiencing homelessness. The second two stats were for a larger age group from 14 to 25. You'll see that abuse and sexual abuse were very common. And then the suicidality, go back to that 4 more ACEs and the increase in suicidality. We know that a lot of these youth have 4 more ACEs. This is a difference as we compare others with national, but what about with youth that experience homeless and the adult who have an onset of homelessness? So youth onset homelessness were more likely to have a diagnosis of major depression, bipolar, schizophrenia, schizoaffective disorder relative to the adult onset of those experiencing homelessness. What is really high in this group here is a schizoaffective disorder. It is 50% higher if the youth had homelessness onset versus adult onset of homelessness. What we do know is mental and behavioral health treatment helps. Without the psychological and safety support, an estimated 50% of transition age homeless youth continue experiencing housing instability and or homelessness into adulthood. An interesting side note, and I just had to build this in because it blew me away. And so if you want a good research project, in this study, there were a high frequency of self-reported head injuries by youth experiencing homelessness. There was no reason given. They didn't know why. It was kind of a variable that they didn't expect to find, and they did. So they did say there's need for more research on this. Is it related? We don't know. But again, it disproportionately and it's statistically significant high number had a head injury. So we'll take this all back to where we all started, Psych 101 back in our lovely undergrad, but Maslow's hierarchy of needs. And this really forms a lot of what the youth tells us about treatment and interventions and how to connect with them. Youth that are experiencing homelessness are at the base of this triangle. They're the physiological needs. They need housing, they need food, they need shelter. And if they can't get that met, there is no upward ability. So as they come to us for care, medical, mental health, treatment, whatever that may be, a lot of them will say, we're not ready to elevate up that triangle, we're stuck down at the base, and that is our priority. So what we're going to go through this next part is just what are the treatment barriers, intervention, recommendations, and action steps that we can all take. And that's what we'll be covering for the rest of the presentation. So based on what we've talked about so far, what do you think are some of the barriers for youth mental health treatment? And this is where the Jeopardy music would be nice.
Transportation availability, accessibility, lack of access, stigma, insurance, lack of access, the ability to pay, parents being able to get them to the sessions, getting them appointments, availability, buy-in from the youth, insurance, family support, patient readiness, lack of understanding of mental health issues, lack of mental health providers, transportation,
We got it.
insurance, stigma. Yep.
You are hitting a lot of the major ones. And then I also will say what surprised me is there's some ownership of us as providers in here, where you say that we don't get what it is like for them. And so we miss a lot of our opportunities. So these are the top reasons that the youth reported that were barriers. The number one thing was difference in priorities. We as providers, we want to prioritize what we want them, what they're coming in to see us for, whether that's medical, mental health, or psychological safety or safety plans. The youth who lived homelessness said that's not what is important to us. We have to prioritize what we're focused on is housing, food, clothing, places to wash or use a restroom over seeking any kind of healthcare or mental health treatment. They also don't trust us. Very clearly and evidently, overwhelmingly majority said the whole system, we don't trust you all for their own reasons. What we have learned and what we've done here is what we call the Q-tip, quit taking it personally. So we tell our team members here is when their reaction doesn't match, if you're really trying to be helpful and there's a lot of resistance, it's probably not about you, it's about something with them. So we Q-tip that, don't take it personally, so then we can really focus on what's going on. They also, one of the biggest barriers is a fear of judgment from providers. And I think there's mentioned quite a bit, stigma, the shame, the embarrassment. There's also a lot of feeling scared because if they tell you that they don't have a house or they're experiencing homelessness, a lot of us are going to call and report that. And that is that whole getting back up in that system when they finally are out of it, that is something that is one of the reasons that they won't seek treatment or come in for help. They've also had very negative experiences with the healthcare system. They talk a lot about the stares, the looks, the comments, being dismissed, the long wait times as they watch others go back. They're embarrassed about their own hygiene when they come in. They're talked down to. And we also know that there are sparse and poorly funded healthcare options in high poverty areas. I think we heard this pretty good, that the no or unreliable transportation, a big issue for a lot of our people in Louisville. So if we think about our public transit system, we don't shovel sidewalks. So if it's cold or it's snowing, they're standing in snow waiting for the bus so they can come to their appointment. So they have bigger issues as well in the community, but it is just here with this population, it's one of the reasons. One of the things is they say they feel disconnected with us, that we have these assumed needs and the treatment targets. And one they mentioned was substance abuse. You'll see a high percentage of these youth have substance abuse issues. And what they will say is, we're not interested in that treatment. When we come to you, forget talking about it, forget addressing it, we will walk out that door, because they report that substance abuse is the way they cope right now with their experience of homelessness. And so that's a big disconnect for them, is this is what they're using to survive at the moment. This is what's getting them through the day and the nights and the cold nights, and that we want them to stop and they don't have anything to replace that. And so they really will disconnect from us and not come back when we focus on that very early in treatment. One of the biggest things that surprised me, I think a couple of you all mentioned it, which was awesome, was they're unaware of resources. 57% of youth who needed services did not seek them out because they didn't know where to go or didn't know how to initiate engagement in services. A lot of the youth will talk to us about it's overwhelming to go in. We give them 20 forms and say, here, fill them out. They don't feel competent, they don't feel able, they get embarrassed. And so even the thought of doing that can be overwhelming for a lot of these youth. So what can we do? You will see in the back of my slide right here, it's a watercolor. It says trauma-informed care. It's going to permeate everything we do. Everything, all the support, all the treatment, all the interactions must come from that trauma-informed lens. Say be open, be innovative, because one of the good things that come out of COVID is the use of technology and treatment. And within this population especially, they tell us to embrace technology. The research says there's a high acceptability, high attendance, and high rates of satisfaction when they have a cell phone preloaded with mental health app-based intervention. Also, our targets need to change. A lot of times we'll go 12, 20 sessions, different points of in longevity of services, but these you say we have to be brief. We need to design and target interventions that kind of focus on a single point of intervention for this population. And we'll talk just a little bit about that here in a second. Talked previously about substance use interventions and how we're not connecting with them where they're at. Really what we need is some substance abuse interventions that are specifically researched and targeted for youth that are experiencing homelessness. Again, because of the way that they're using this as a coping skill to survive in the moment. We have to reconceptualize a treatment support. 49.4% of youth attended the first session only. And of those, so 50% didn't show, not too uncommon, I think, but after that, only 13% of that initial group attended a second follow-up appointment, and it dropped off to under 2% after that. So, as we said before about brief, targeted interventions, we have to have interventions that fit those that are supportive. So really what the research says is conceptualize the first session as a primary and maybe the only intervention point. So if that is the case, as providers, you'll have to think is, if they leave here with one thing I want to impart with them or do, what would that be? A lot of us are probably gonna say safety. Also motivational interviewing. This is one that we all have, very general, but it does work with this population. It helps them build and increase that buy-in acceptability. So really building that rapport and seeing them and as humans, connecting with them. Again, a lot of those barriers that they had said prevent them from seeking services. These are things that we can do just by being kind and considerate and compassionate. Last thing that we'll talk about for this is creating youth mental health ambassador programs. What we can do as providers is help support or facilitate, but not run those. We know there's, we've had a youth advisory board. It had a lot of good forward momentum and changes as a result of that youth advisory board, because it was ran and the group membership was all either current or former youth had experienced homelessness. So what mental health ambassador programs do is they give you greater social clout, and they serve as liaisons in the reintegration of the underserved youth into the mental health. So they help break down the barriers that the youth are reporting.
Okay, I think this is our last poll of the presentation. So one last poll question. So myth or fact, homelessness is caused by a bad choice or series of bad choices made out of personal failures?
I am pretty positive this group, they're gonna get this one very clear.
Everyone's saying that it's like.
Yep.
Yep.
Good. Correct.
I'm so glad, because if you didn't, we're gonna be a little worried that we really failed in this presentation.
Right. So statistics from across the country show that homelessness is most strongly correlated with the availability or lack of low-cost housing. Even when tested against mental illness, drug use, poverty, generosity of public assistance, low-income mobility, etc. Housing works, especially low barrier, low entry housing first. And I'm going to talk a little more about that.
So one of the things that they wrote when we talked about the myth or fact, we were researching this, it's a pretty powerful political statement, but we've kind of saw this theme permeate through a lot of the research is homelessness is a policy and funding choice made by governments. It's not a personal choice made by individuals. So let's talk about what Louisville just released here last month, as a matter of fact.
Yeah, so Mayor Greenberg recently released the My Louisville Home Plan, I think on October 2nd. And it's a pretty comprehensive plan and ambitious goals for the community around affordable housing. So I'm going to read the quote. Safe, affordable, quality housing is a basic human need that's going unmet or being inadequately met for far too many people in Louisville. It's the foundation for every family and everything else in this life. This must be present in all neighborhoods, not just other people's neighborhoods. And, the city estimates as many as 50,000 households lack affordable housing, which is a direct result, obviously, of income. The median home price in Louisville has risen 48% since 2016, while median income has only risen about 29%. The average rent for a one-bedroom apartment in our community is approximately almost $1,200 per month, which is affordable to households earning at or above $47,000 annually. So we've got to somehow find a way to create we're about 35,000 units short if you look at the need for affordable housing in the community. And this particular plan provides funding for about half of that need, so about 15,000 new units of housing.
So we put this in for those that maybe new in their career and are looking at home buying and what's the budget. So what we know is a rule of thumb, anything more than 30% of your income going towards housing is considered a housing cost burden. So just kind of look at what you make. You don't want to go over 30% because it will cause additional burdens.
All right, so what can be done? Obviously, more housing, right? So not enough affordable housing is available. There are very few property owners open to renting to folks like my population, homeless young adults 18 to 24. And not only that, when we do place young adults in apartments, they're often, well, 100% of the time they're located in West Louisville or South Louisville. So we don't have that diversity throughout the community.
And if you go back to transportation, it limits, right? If that's where you're at, the TARC buses only go so many places, or it takes so long to get everywhere else. So you're really even limiting employment options.
That's right.
When you pivot them in certain areas of the community.
Yeah. And, you know, Louisville's also unique in that we do not have a dedicated overnight emergency shelter for youth and young adults. So there is a day shelter option with Tailored at 7 counties. And then Sweet Evening Breeze is doing some day shelter work too. We have no dedicated overnight shelter for this population, which is another problem. Salvation Army has a few beds, but they're adjacent to the adult population, and it's not as sustainable as it should be.
And the youth, they don't want to be in the adult shelters. They feel very unsafe. There's a high rate of victimization. I mean, you're putting youth, a lot of youth who were, you know, in the foster care system or product of the system that don't even have the skills. Think of a trauma brain and where they're at developmentally, not chronologically, developmentally, and the impact of trauma on the brain. You put them with somebody who's 50, 60, with a lot of life experiences, street skills. Again, they don't feel safe in shelters. So a lot of them will not go. And for our youth, they don't have an option. There is not a place that has a youth shelter just for kids.
Mm-hmm. There's the street outreach component is another thing that can be done with, I mentioned earlier about YHDP. We were able to, through that funding, refund Safe Place through YMCA. So they have a street outreach team dedicated to youth and young adults, but we need more. And there are several private, you know, non-publicly funded street outreach teams that are definitely help, but there's always ways to get involved with that. We need a community mental health treatment that is low barrier, dedicated, like such as at the Tailored Center, where it's more of a drop-in, one-stop shop, you know, where service agencies can come together. And just, you know, we just need more ways to access treatment. You want to take it?
Yeah, so I'll do a couple. So I think on the street outreach, which is important, is this, if you're not aware, November is National Youth Homeless Awareness Month. So it's going across the country. It only takes one person. We drive by, and I'm guilty. I don't like to look on Jefferson Street. There's lots of homelessness under that viaduct, and I just drive by all the time. We act like the problem doesn't exist, but in Louisville, we are in a crisis situation with homelessness at this stage. And so try to do things, but a lot of other things we can do. Remember, it only takes one person to impact a youth. If you look at everything we know about youth, regardless of homelessness status, they need that one person to champion for them. So we talk about outreach, compassion. It just takes one person. So visiting, saying hi, donating supplies that they can do critical needs items, especially if you're supposed to have a very cold and snowy winter. Those are things that we can do. Joe talked about the community mental health treatment that is low barrier. It really means we need to be out there where they are. They're not going to come to us.
That's right.
We have to make that shift, which is why going out to them, in various forms, and also the tech things are very important. I think we're probably going to see that more with youth anyway. Even if they're not homeless, just in treatment in general, they are on their phones all the time. We live on them. So that's going to be important. Sorry, that was my computer. The one-stop shop. So what they're talking about here that they say can be very helpful is we need a kind of an all-encompassing place for them to stop. So if we want to look at healthcare and mental health for them, that needs to be included in a place or an agency that also has showers and food and laundry. What they will connect with more than anything initially is case management, because case management links them to those basic resources so they can get their needs met. So if you go back to Maslow's hierarchy needs from the beginning, basic needs need to be met before they're even willing to open up or seek any type of treatment. Having a place where all that's included, one-stop shop, will be very, very helpful, and putting a different providers and array of resources in that area. They also need more ways to access treatment. So we did talk about youth shelters, drop-in centers, community clinics, but again, emergency departments, those type of things, where they have to travel a lot of times to get services, and go to transportation, no or unreliable transportation. It's not in their wheelhouse to make it to where we are at. And then the last thing with this is what can be done is we have to include the youth voices. As we have shown you previously, we are not connecting with what their needs are, and what they say is what's going to help them. We place our adult views, our life experiences. And I don't know about you, but I've already felt really disconnected from my kids who know technology and things that I never know. In my framework, we didn't have cell phones growing up, but now at 2, they can all swipe and know how to open things and close things. It's amazing what they can do. We have to, and I'm going to draw this analogy, is they're going to be better at us, our kids right now have tech. We have to move towards what they need, what's important to them, how we can take where they're at, and we have to adapt for them versus vice versa, which is what we have done in the past. The last thing I'll say is listen. More than anything, that compassionate, that listen to care is one of the best things that we can do to start breaking down these barriers. We're talking about be the change.
Yeah, so here's kind of some action steps. I think we've heard today that housing really is the key. So, and part of that is that existing housing resources absolutely work. Both permanent supportive housing programs and rapid rehousing programs, which I administer here at Home of the Innocents. We have well over 95% housing stability outcomes, meaning that even the most co-occurring acute individual, once we get them in an apartment and wrap services around that apartment and that individual, they are 95% likely to stay to up to 2 years in the apartment.
And it kind of goes back to, you have to have that housing. Everything else we want to do doesn't exist without that housing first.
Right. So we have existing resources that work. We just don't have enough resources. So that's where the advocacy piece really comes in. And the Coalition for the Homeless in Louisville does a fantastic job. If you would like to get more involved, George Eklund is the director of advocacy there, and the numbers on the slide there. We need more private dollars invested in homelessness. I went to a conference about 10 years ago in Denver with their whole homeless staff and their mayor, and Quiznos, the foundation, gave a $3 million grant, and they were literally using that private money to pay for 1-bedroom apartments for single homeless young adults in the community. So it can be done. We just don't have a lot of private investment. We're having to rely heavily on public funding and the public grants. There's other ways to get involved. Donate time. There's money, food, clothes, hygiene products, all that can go through the Coalition for the Homeless or directly to one of the emergency shelters. So you got Wayside, Salvation Army, St. Vincent de Paul, Volunteers of America. Those are in the Healing Place. Those are the big 5.
Let's talk about getting involved. One of the things that we know that's critically important for foster youth in residential care, and youth experiencing homelessness is mentorship. So that, as we talk about what we change, how we get involved, how we change the entire system, is that takes us as adults to be the mentors for those children who lack that stability of a home, lack that stability of a family, to help show them and care about them and be their support and champion in life. And then I'll go back to the private donors and foundations. The Quiznos, we talked about that, but one of the other things that we talk about is different ways, because $3 million, I mean, that's not pocket change. But if you look at for private foundations and donors, is you can consider sponsoring rent for a homeless family. I think it's $10,000 for the year. It covers a family home for an entire year. But also there's other ways such as homeless vouchers for youth experiencing homelessness. It gets them off the streets temporarily while they're waiting for a potential housing voucher or subsidy. So our wait list right now for our youth homeless program is almost 200.
Yeah, we've got
and growing.
We've got 176 young adults between 18 and 24 that currently meet the federal HUD definition of homeless that are waiting for any kind of housing subsidy to get off the streets, now shelter.
Yeah, they're literally on our streets right now.
Right.
And that's because there's just not enough housing for them.
Well, and that's a great segue to the need for Section 8, right? So Housing Choice Voucher Program, Section 8 is administered by the Louisville Metro Housing Authority. They do an annual plan, making sure we're there to comment on that annual plan, specifically to say that Section 8 vouchers should be dedicated to the homeless, not just the typical low income. There should be a set aside specifically for the homeless population, because we need all the housing we can get. And you can make a comment. The big takeaway is that let your elected officials know that this is important, whether that's at the local and mostly local and federal levels. The state doesn't do a whole lot around homelessness. It's mostly through Kentucky Housing Corporation.
But also remember, we don't have a definition for youth homelessness.
That's right. That's right. And then, and Melissa had mentioned earlier, the Path to Action series. It's free in-person community discussions around homelessness and housing. We've got the link there on the slide if you would like to get more involved with that.
So what we are going to wrap up with before any questions and answers is we have a brief video where we've talked about what works. And this is one of Quiet that went through your program. There was a youth experience of homelessness and what the program gave them and where he is at now. And he will warm your heart because he is a wonderful young man. And it's just great to know, brings joy every time we see him and talk to him.
Innocence has been working with children and families to live life to the fullest, but the organization is also making sure homeless teens and young adults are not forgotten.
WDRB's Molly Jett explains they're helping the youngest homeless population find a home.
Pathways Home is the primary housing provider for homeless young adults within Louisville. They serve 18 to 24-year-olds and give them the resources they need to be independent. Malik Madol grew up in foster care, but became homeless when he was a teenager.
I was struggling. I had nothing but my ID and social.
He left West Louisville and found the home of the Innocents when he was 17.
They were like seeing how hard I was going, what I was going through as far as to trying to get in school, trying to get home from being homeless.
Madol says their program, Pathways Home, changed his life.
And just seeing myself now is just like, I wouldn't have traded for the world.
The 25-year-old says the program helped him become a singer. It taught him life skills like financial literacy, and it connected him to housing.
Building up the skills so that they never need assistance again.
In 2015, the Coalition for the Homeless counted 418 young adults aged 18 to 24 living in an adult emergency shelter or on the streets.
It's really providing the stability needed to make transformative life enhancements.
Hamilton says they help the ones that are the most vulnerable find jobs.
We're going to school, we're going to work, we're getting jobs, we're getting scholarships, we're getting grants, and these are the kind of things that's going to keep motivating.
Hamilton says for the majority of the people they help serve, this program is their last resort. They've helped about 2,000 homeless people in the last 2 decades. In downtown Louisville with photojournalist Josh Horton, I'm Molly Jett, WDRB News.
Nice job, Jen. So as we wrap up this, we're going to open it up. If there's any questions that are lingering out there, we are happy to take those. Carrie's watching our chat box. But the big takeaways from here are we have a youth homelessness problem in this community. We have a homelessness problem, period, in this community. We know there's a disproportionately higher number of our foster youth that are in this, the youth experiencing homeless population. Altogether, youth homelessness, their statistics on their mental health, their ACEs, their issues is extremely higher than any other, if you compare it against any other same age groups or even the adult onsets, we see, again, higher statistics for this group. There are things that we can do. There are treatment options. we have to pivot to what they need versus putting what we think they need on them. Connect with them, build rapport, change the way we look at interventions and treatment, and go to them versus the typical is everybody comes to us. Whether that's healthcare, behavioral health, mental health, we typically have brick and mortar buildings and ask them to come to us. Not a good idea because this population has trouble with that transportation piece. And then again, so adapting to them, what we can do, and just some other things that we had talked about is advocating, going back to what's needed in the community to make a difference, because we're going to be tackling this for a while. And in 10 years, I don't want to be having this conversation again, where we have more than 35,000 right now waiting, or we have more than that we're aware of just for our program, 200, almost 200 youth literally living on the streets or in an uninhabitable place because we don't have anywhere for them to go. I think we can do better, but it takes all of us working together. And then again, the one-stop shops, biggest things we can do. We're all providers, all different types. We coordinate, we collaborate, we partner to get them their basic needs met, but then we're there to provide medical, mental health, and then the different ways that we can approach them and engage them in treatment with compassion and kindness, and be mindful of some of the preconceived notions and stereotypes that they get, the looks that they get, the looks that we pretend or kind of ignore as we drive past them. So all those things are different pieces that we can do. Any questions before we wrap it up?
So Gary Hall asked, are there programs to support adolescents who age out of foster care as a critical need?
So very interesting. There are, and a lot of them require them to re-up with a cabinet. So that's going to be, so you have independent living facilities, and the disconnect again, what we think they need and what they need is when they age out at 18, and they don't have to be in the state's care, and they don't have to be under DCBS anymore and in the system. They're like any other 18-year-old when you kind of graduate high school and for college. They're done, right? They want that independence, they want that freedom. And so a lot of them will not re-up in the system. I mean, as they sign on to continue to participate in the system, which will give them access to that transitional age support and services. And so that is a gap that I think that we have here, just not in Kentucky, but across the nation. We have to be more forgiving. And expand that age group, allow them multiple times to re-up, to change their mind. It may take them a year. Kentucky has done really well of that. The cabinet, I want to give them a shout out. They have made at the very beginning, it was at 18, they re-upped, or it was or all or nothing. They've now changed that. There's a couple times now that they can change their mind. But again, we need longer times. It takes them a little bit. Sometimes they have to get out there. And again, 20% instantly homeless, experience that, and they're more likely than to come back to say, hey, we need some help, and then change what we're different now, right? If you're under the cabinet at 18 and then you age out, the cabinet's role or DCBS's role in their life is very, very different. They're not their guardian that are looking for their placement. It's how can we support you? How can we get you with education and housing? So it's changing their mindset as well.
Another question from the chat was Bill Harden. He said, are there peer advocates engagement efforts? The position that they don't trust us as professionals is very real.
Yes, and there's limited ones. And one of the major obstacles that we have is the lack of funding for those positions. So you talk about funding and billable and things like that, is it becomes business and treatment. And so there are some peer advocates. There's the national, I'm going to get the title wrong, the Foster Youth Board that we have right now in Kentucky. You're going to hear from a panelist here. One of ours that was in foster care has been a part of that, but there are some efforts to join youth to lead that, but it's few and far between, and there's not been a lot of support from the outside. So engaging them, helping to connect them, and I think you're right. It's something we're going to do better at.
One more question that we have is there a high pregnancy rate for homeless women and young girls?
Yes.
Yeah.
How is housing needs addressed for this specific population?
So if you look at the statistics from my program at Pathways Home, which is all formerly homeless young adults 18 to 24, over half have children of their own. And so it's I always say it's a lot of kids having kids. There's definitely that. So we're over half with small children in the household, which of course, requires more housing. It requires a larger unit, and if you have a lot of families, you can do less with a grant. which is, so it means you wind up taking less in overall. But yes, it's very prevalent. And I did want to add a little bit more on the peer support. A lot of the homeless service agencies do utilize peer support, especially the shelters. There's quite a bit of peer support there. And we've had a few peer support specialists for the 18 to 24 age group, mostly through St. Vincent de Paul, but there are peer supports out there.
It's not enough. All right, I know we're at time, so thank you all very much.
Thank you so much, Melissa and Joe, for an excellent presentation. I think it gave us such valuable inspiration and information on this topic. I had one quick question before we transition to our panel. If you are in the office and encounter a homeless family, what is your first step as a physician or a psychologist, or so what do we do first?
Well, I can tell you what we do first, and that's focus on housing, right? So
Okay.
Our first step, you can't, in my 19 years, you can't do anything else unless you have a roof over your head. So that's the Maslow's hierarchy that we discussed. Really any kind of mental health treatment or substance abuse treatment, that's going to come later. So the first, when we get a new referral, our first 3 weeks are spent absolutely focusing on looking at apartments, doing an intake assessment to figure out what's going on, and then building a case plan from there so we can wrap services after the apartment.
And so would we refer to an agency like yours, or
we'll get it. I think we included with you all as a handout, the Louisville Street Tips, which has a lot of that information in there and where to connect. And I think what Bill and Joe is, we have to focus on housing, but if you're a physician and you have a family come in and they're experiencing homelessness, it starts with that kindness, compassionate, giving them hope about potential housing, the coordinated care of entry is where they'll start. But then you can still have that health, the physical needs, mental needs that they have in that moment. Once you kind of acknowledge that, and it's again getting that buy-in from them, that you can be trusted, that you're not going to immediately call the cabinet because they don't have housing. Because again, that safety planning, what they can do, where they can go, those resources, that will hopefully give you that little bit of buy-in, so you can get to why they were there to begin with, which may be a sick baby or different needs right at the moment.
Yeah, the Louisville Street Tips, it comes out once a year. It's up to date with all the shelters and the housing providers. So if everybody can have a copy of that.
Attached to this. Yes, they all have that.
That's the key.
Right. Thank you so much again. Very, very much appreciated. It was an excellent presentation. All right. And now we're going to transition to our panel, and I am going to turn it over to Dr. Joe Bargione.